second in this series of webinars from SARA. This time we've got a focus on COVID and some three very different talks about the COVID pandemic. First of all, I need to give you some housekeeping. We need to remind you that you unfortunately can't share your audio or we can't see you, but you will be able to post your questions. There is a Q&A button at the bottom of your screen, and you can click on that and post your questions. We will be looking out for them so that we can ask the speakers on your behalf the questions that you've got. Do keep them running. Don't wait till the end of the talks. Keep them coming in as you think of them. If you like another one of the questions somebody has asked, you can add a thumbs up icon, and that does mean that we'll prioritize those questions if we've got more than we've got time for. I need to let you know that the webinar is being recorded and it will be posted on the YouTube channel in due course, so that you'll be able to watch it again or encourage others to watch it. I also need to thank Mylan, who sponsored this event, and to make it very clear that Mylan have given us an educational grant for this. They've had no input of any sort into the choice of topics or the speakers and the talks that they're giving. That was entirely in our control, and we're very grateful to Mylan for sponsoring this so that we're able to bring this to you this evening. So moving on, we've got three talks for you about managing COVID. First of all, the practical management in the community. Then we're going to be thinking a bit about post-COVID and the role of rehabilitation. And then we're going to be looking at the psychological impact of lockdown, which is something that's been concerning us, I think, quite a lot as to how we're all coping with this situation. So without more ado, I'm going to introduce Professor Brian McKinstry, who's been a colleague of mine for many years. Brian is a GP and he has led the Telescott programme of work. So he's very interested in telehealth, and I think he's going to share some ideas about telehealth in the context of COVID. Brian thought he was retiring a while ago, but then COVID arrived and he got pressed into coming back and doing some clinical action again in the COVID centres, and he's going to tell us a bit about that experience in managing COVID in the community. So thanks very much, Brian.
Thank you. Can you all see this slide? Yeah?
We can.
That's grand. So I'm going to talk a little bit about the background to COVID, which I'm sure many of you are familiar with. The need for early identification and deterioration in this group of people. And then something about telemonitoring of acute COVID. If we've got time at the end and people are interested, I could talk about the impact on other long-term conditions, and I could speak a little bit about the technology that may be adapted for long COVID, but I'm sure that Roberto will actually be telling you a lot more about that. So you know it's a highly infectious disease and it's mainly airborne, and it doesn't affect everyone equally. Some groups are much more likely to be affected by it. And at the moment, distancing and quarantine is the only effective prevention, although we have this vaccine coming soon. The early use of steroids, antivirals, anticoagulation reduces death and shortens admission. So it's a multi-system disease, but it primarily affects the lungs. But there are also receptors in many other organs. But the main features are respiratory with cough and dyspnea, but also fever, anosmia, diarrhea. Acute respiratory failure is the main reason that people wind up in hospital, although thrombosis is also a major feature. So, and as we know, there are persistent symptoms in a substantial number of people and affecting many systems. So I'm going to talk about acute respiratory failure in COVID. So around 1 in 6 need support of some kind. So about high flow oxygen, CPAP or ventilation. And this failure occurs relatively suddenly. And patients become very breathlessness very quickly over a short period of time, and often has fallen oxygen saturation. But Some patients develop hypoxemia with relatively few symptoms of breathlessness. Sometimes they're still breathing quickly, but they don't feel particularly breathless. And there are all sorts of stories. Roberto will be telling you about these as well, I'm sure, of people turning up in wards feeling not too bad with oximetry of 78 and 80. So it's a very strange illness. Dehydration is particularly common if they have been hyperventilating. And falling oxygen saturation or increasing breathlessness requires support, and early treatment is helpful. If you look at the mortality associated with presenting saturation, this is some work that's just come in. It's from medRxiv, so it hasn't been fully peer reviewed yet. But you can see people who present with a low oxygen saturation do much worse than people presenting with a higher oxygen saturation. So early identification of deterioration allows early intervention, and the degree of the hypoxia predicts the outcome. Some people who develop severe hypoxia have relatively few symptoms. And we know that people who present late with more severe symptoms do much worse. And some groups are much more likely to present late. And these are the groups, as you can see, healthcare workers present very late, people who are obese, people in ethnic minorities, some people with asthma present late as well. So it's interesting that some of the groups that seem to do least well are those that are represented by the how late they present. So we need a system which identifies deterioration and encourages contact. So we need both of those things. So we came up with TeleCOVID, and this is a system which asks patients to do twice daily readings and to submit these. So the patient completes a symptom questionnaire, does some readings of oxygen saturation, temperature, and pulse, and can send this either by an app on the internet, by SMS, or by touch tone phone. Now the patient gets an automatic response that the symptoms of the readings suggest some sort of deterioration. So either to call a center or to call 999. And then they can get advice or be taken to hospital. So we asked them questions about breathlessness and of cough and fever, and we asked them twice a day to do oxygen saturation and pulse, and then we asked them to do oxygen saturation after a 1 minute brisk walk. Some controversy about that, whether we should be asking people to walk or maybe doing sit to stand, but we're starting with walking. And we also asked them to check their temperature. So in selecting patients for this system, it'll be people initially attending assessment centers, but we believe that as time goes by, these people attending general practitioner, emergency department, or even people who've been seen by paramedics may well be put on this system. These are people who are considered well enough to manage at home, but at risk of deterioration. We can offer people at moderate risk a symptom tracker only, but people at high risk will be offered monitoring with an oximeter as well. And the groups that we're thinking of at the moment is anyone over the age of 65 or under 65 with a potential for deterioration, significant risk factor, or if they present badly, if their oxygen saturation at presentation is 95 or less. So at the moment, we're not including people with COPD, bronchiectasis, interstitial lung disease, or pregnancy. They're just given a symptom tracker only at the moment. We haven't started this ISNAB, but that's the plan at the moment. This is just more or less what I've been telling you about how these people get into the system. If they've got an oxygen saturation of less than 94%, they don't get entered into the system, they get referred to acute medicine. And if more than 94% and they meet the criteria, they are onboarded and they choose what type of contact they want, whether they want to use an app, SMS, or a touch tone phone. We take some baseline recordings, oxygen saturation and pulse, and then they get set up on this. So the triggers, if it's amber, if breathlessness is worsening and breathless on minimal effort, they're asked to phone for advice. If their oxygen saturation is falling, so if their previous oxygen saturation is falling and it's triggered at 94 or 95, they're asked to phone for advice. But if their oxygen saturation is steady at 94, 95, they are not told to call. If the temperature is greater than 38.5 at any time, or a temperature of greater than 38, that should say, sorry, for more than 5 days. If they are breathless at rest and unable to complete sentences, or if their oxygen saturation is below 94, they're asked to call 999. So I'm going to actually show you this live now, actually. So what could go wrong, as they say. So go into my email here. So I've got a video if this doesn't work. Right, so the new share is this one. So do you all see that? So here we see the symptoms of people. So they get asked if they're breathless, and if they can click not breathless. If they click that, they don't get asked any more questions about breathlessness. If they click less than before or same or more than before.
I can't actually see this at the moment, Brian.
Oh, can't you? All right.
The screen. I've got a thin, narrow bit of screen with not much on it.
All right. Okay. Right. That's unfortunate. Shall we try a different way of doing this?
Ah, that's looking better. Is this NHS Scotland? Is that where you'd like?
That's the one. Yeah.
That's looking better now.
Can you see that?
I can see that.
And you can see the questions underneath it.
Yes.
Are you feeling breathless? Right. Okay.
Yes.
Well, let's hope this continues to work then. So if I say I am less breathless than before, I comes up with a further question: am I breathless at rest or having difficulty completing a sentence? And if I say no to that, it moves on to other questions. If I say that it's the same or more than before, then it gives me this additional question: are you more short of breath than you usually are walking across the room? And if I say yes to that, I may be asked to check my pulse oximeter and to contact for further advice. I'm going to say no. So it asks you a few questions here about coughing. Are you coughing more than usual? If you say yes, it just gives you an advice. This doesn't trigger a call to anyone, but it just gives some advice on what to do about coughing. And again, muscles aching tells you to maybe take some paracetamol for that. Then there's a question about, in the last 24 hours, have you felt much weaker or tired? And if you answer yes to that, the reason this question's in is because that's often associated with a drop in oxygen saturation. You are asked to do your pulse oximetry. If you say no, it moves on to the next question anyway. If you say yes and you don't have a pulse oximeter, then it will advise you to get in touch with the center. Okay. Let's go no, and we'll move on. It asks you about if you've got a thermometer. And if you say yes, then it asks you for the reading. And you just type in the reading. So if you write 38.6, it tells you to get in touch for advice. And if you make it 38.0, it asks you if you have a temperature for more than 38 for 5 days or more. And if you say yes to that, it tells you to contact for help, and then you just submit that. Now I have missed out the oximeter. If you've got an oximeter, then it asks you to put in your resting oxygen reading, and you could put in, say, 95, and it says a little low. Now it's saying that because the last one I put in was 96, but if I put in 96, it'll be okay. Then it asks me for my heart rate. And if the heart rate's more than 100, it triggers a response, a resting heart rate of more than 100. And then it asks you to do active oxygen levels, moving back and forward across the floor. And again, if you put in 95 there, 95, it won't trigger anything. And then it asks you about the temperature, and that's it. So I didn't do that in the order that a patient would have done it, but that's more or less it. You just submit that, and then it goes to the center where it can be seen if necessary. So I'm going to stop sharing at this point. I'm happy to take a few questions.
Oh, thank you, Brian. Found a question here, rather, I would say a very sensible question, really. If people are unwell, how well will they be able to fill that in?
Well, if they're very unwell, they're given a piece of, this isn't the only thing, information they're given. They're obviously given written information as well. And they're told that if they're unwell at any time, if their condition is deteriorating, then they should get phone for help. So if they're really ill, they should be phoning for help.
Overriding that. Yeah. Now, from my perspective as a GP, my problem is knowing, trying to distinguish. You mentioned, for example, that people with asthma tended to present late. And I'm finding quite a problem sometimes, doing phone calls to people, as we all are in primary care, and the person with another respiratory problem, and you just think, is this their asthma? Is this their COVID? Do I need to refer them to a centre like you? And you're not interested in the COPD ones, I heard you say. So can you help me through that sort of practical problem that as primary care we have in terms of distinguishing where we should really be worrying about COVID and where we can comfortably say, oh, this is just your asthma, or this is a common cold, or?
Well, it's usually associated with a fever, often associated with quite extreme, people feel quite unwell with it, which people don't normally with asthma, and they don't normally wheeze with COVID, whereas with asthma, you would normally expect them to be wheezing. Sometimes the only way around this is to see people and examine them. I know that sounds terribly old-fashioned nowadays, but I think sometimes that's what we just have to do.
But then we have to arrange them to come to a hot site, and it's quite a performance, isn't it? And I think it's quite a challenge for us.
It is a challenge. I think it's a really big challenge. I think flu is going to be a really big challenge here. That if distinguishing between the early stages of flu and COVID will be quite difficult as well. Yeah.
Why aren't you including COPD?
We will be including it later. It was just really because of the interpretation of the oxygen saturation was just a little bit difficult. We will probably run them down a COPD route rather than a COVID route. But we're not including them at the moment. We want this to work to start with, obviously with the least complicated cases. And then we'll probably include people with COPD later. And the same with pregnancy. My understanding was that pregnancy have slightly different oxygen saturations as well in late pregnancy.
Okay. Now, do keep some chats coming. I've got one here from Una McFadden, who wants to know, do non-English speaking patients bypass this system? So how do they cope with this system? Do they go to their GP? What do they do?
So non-English speaking people, the system at the moment, the messages are only given in English, okay, on the app at the moment. We have produced translations of these, which will be written down for people. It would be quite unusual, I think, for someone to be living in a household where nobody spoke English. And I think that's all we could hope for. But we haven't got this coming out. I mean, how many languages would we put this into? It would be quite difficult, I think,
It would. Now, do keep some chats coming. There's somebody here who wants to know, has this already been rolled out? Barbara Hughes is asking.
So Barbara, we're hoping it will roll out. We tried it on Florence, the system called Florence, which is an SMS-based system in Highland, and we did that in the early part of the summer. But unfortunately, not unfortunately, all the cases of COVID dried up in Highland in the summer. So we only a very small number of people tried it, but it worked quite well. But we moved it onto this system called In Healthcare, and that's what it's running on at the moment. It's a much more sophisticated system. So it's going to roll out, we hope, in the first area in Scotland at the beginning of December.
Okay. And we've just got probably time for one more, and I'm going to ask you about this being a medical device, because surely this is taking decisions about what people should do. How did you manage to get that through the system, given the medical device legislation?
So in healthcare has got all the medical device approvals. So we just took it that it had that. I think quite a lot is happening at the moment with regard to, also this is just backs up. It only backs up the written information the patient already has. And that's made very plain that the primary source of their information should be the written information that they have.
Yeah.
But I agree. It's what you'd call grey. Maybe not so grey.
You know where I'm coming from, I am sure.
Oh yeah, absolutely.
If this hadn't been COVID, I'm not sure it would have got through.
I know. Well, hopefully it'll only have to last 6 months.
Okay, thank you very much indeed,
Okay,
Brian. That was really interesting to hear, how this is working and how it's going to be rolled out. So thank you.
Okay, thank you.
And I'm now going to move on to our second talk, which is from Dr. Roberto Rabinovich. And Roberto is an expert on pulmonary rehabilitation. And of course, COVID has had a couple of impacts on that. First of all, it stopped it because nobody could go to pulmonary rehabilitation at one point, but now it's become very clear that it's actually something we really need, and that post-COVID needs to be managed with pulmonary rehabilitation. So as I say, it went from being banned for a short while to being probably one of the most important things we can do. So Roberto, we're looking forward to hearing from you.
Thank you very much. Can you see and hear me well?
I can.
Okay, right. So the role of pulmonary rehabilitation in the management of the post-COVID syndromes. So, I mean, COVID is a new disease. So there is a lack of evidence or a slow emerging evidence for the management of the acute patients with COVID, and the same happened for the management of long-term problems, and that applies to rehabilitation. However, individual problems affecting people that had COVID are normally quite common and well studied in itself. So there are a number of specific medical problems that can affect people that had been affected by COVID, and that will normally be related to the severity of the disease. And I mentioned some of them here. People that have developed ARDS, for example, may present some lung sequela secondary to these. Thromboembolic disease has been mentioned by Brian, and it's certainly the case in patients with COVID. Some people may, as a consequence of this, develop pulmonary hypertension. The heart can be affected acutely, and there might be a number of patients that may have some problems with the heart function post-COVID. And certainly there'll be a number of patients that survive a prolonged admission in ICU that may present in the post-COVID time with a post-ICU syndrome. And those syndromes are, in this case, secondary to COVID, but are not specific to COVID. Other conditions certainly may produce the same effects. And as such, we believe that effective rehabilitation interventions for these people can be given on a reasonable, sound, evidence-based. So now, the problem that we face now during the COVID in relation to rehabilitation, I mean, there's a different situation to the normal, and obviously this situation is adding strain to the pulmonary rehabilitation services, as Hilary just mentioned, on the ability to deliver pulmonary rehabilitation that normally would have received pulmonary rehabilitation, so the services were closed for a while. We still have the problem of bringing these patients together due to transmission risk. And there is also the effect of lockdown and shielding to some of these patients. And sometimes some of these patients had suffered COVID itself, and they had an underlying condition that originally would have been treatable with pulmonary rehabilitation. And all these had contributed to worsen the physical activity of these patients, and also contributed to increase the strain of the pulmonary rehabilitation services. So it is likely that because of the development of post-COVID syndromes, such as the one that I mentioned before, the population that now we need to target to treat with pulmonary rehabilitation may increase, and that will include the usual people that we would have treat with pulmonary rehabilitation and the new population of post-COVID syndromes that will be potentially tributary of receiving pulmonary rehabilitation. So we have the usual users that in the context of the COVID pandemic, they have suffered from social isolation, loneliness, lethargy, physical deterioration and well-being deterioration, some mental health problems, and we have the COVID disease in itself that may end up producing some of the post-COVID syndromes that we measure, and in some people, around 10% of the people, accounting for around 60,000 patients in the whole UK, may have what we now call long COVID. And of course, you know, people that would have had a disease that would have normally be treated with pulmonary rehab can suffer from COVID, which may contribute to worsening this situation. So there is a number of needs to address these, which is basically what we are addressing is cardiovascular, pulmonary and muscular deconditioning, secondary to the factors that I mentioned before. There are problems around the emotional area, neurological problems and cognitive problems, post-traumatic syndromes, post-ICU, and fatigue and pain. So there's a number of things that we can address with pulmonary rehabilitation. So there is a rehabilitation need for these two populations, the post-COVID, but also we should not forget the people that would need rehabilitation, and we still need to provide this service to these people. And there are some barriers as well due to the current situation, lockdown, self-isolation, and also transmission risk, which would impose a risk to put together patients in a rehabilitation session as we used to do in the times before COVID. So who are we targeting with pulmonary rehabilitation? Well, we are targeting, as I mentioned before, the usual conditions that we would have treated with pulmonary rehabilitation. Possibly these patients would have suffered from the consequences of isolation, some of them from COVID itself. There are new patients, probably healthy before, that had suffered from COVID, and some of them may present later on with COVID-related diseases, some of them more severe than others, and there's a possibility of what are called now the post-COVID syndromes that will be related to the way COVID presented, and that can go from myocarditis, problems secondary to acute thromboembolic disease during the COVID, post-ARDS, lung problems, ICU, post-ICU, prolonged ICU syndromes. And we are targeting this population under new circumstances. We will have an increased number of patients, so the usual ones plus the new post-COVID patients, and we have the situation of lockdown and the risk of transmission. So this created a brand new situation in terms of the population that we are treating with pulmonary rehab, and some barriers in terms of delivering pulmonary rehab effectively on these people. So there is a need to developing new strategies to deliver pulmonary rehabilitation under the present circumstances that I mentioned before, now to a broader population, including the usual users and also the new post-COVID patients. And there are a number of initiatives to address these. There are from European Respiratory Society documents based on expertise, a number of articles addressing pulmonary rehabilitation, how to adapt these to COVID. And there is certainly a Scottish government document creating a framework for supporting people through rehabilitation that had suffered COVID-19. So rehabilitation didn't particularly change in the concept of pulmonary rehabilitation itself. And as you can see here on this slide from the WHO, I mean, pulmonary rehabilitation can be delivered in a broad spectrum of circumstances, from a very informal and self-directed approach to a very specialized and high intensity rehabilitation for the more severe patients, which sometimes may even include admission to rehabilitate these patients, and you have a range in between these two circumstances. But there is also a new concept of helping patients to afford what potentially could be a disrupting health problem, and is the concept of rehabilitation. So it's the concept of trying to help people to be able to get to these situations in a more fit situation. And this is not a new thing. It's what we normally would do for people enduring a major surgery or enduring a very disruptive for their health cancer treatment. And that can also apply to COVID-19, particularly in the group of patients that are more vulnerable to have a worse presentation of COVID, such as the population that Brian mentioned before. And rehabilitation components would include self-management to optimize a pre-existing health condition, improving physical function through exercise training, nutritional support, optimizing social connectedness, and, for example, psychological well-being interventions to optimize these aspects. But as I was saying before, the concept of pulmonary rehabilitation didn't dramatically change. It's just been adapted to these new circumstances, and as such, it is, as usual, a multidisciplinary approach targeting the different patient needs, and goes from medication management for those that need it, smoking cessation, occupational therapy, psychological support, nutritional support, social support, education, physiotherapy, and of course, what is the cornerstone of pulmonary rehabilitation, which is exercise training. And it still works the same way. The main aim is to improve the exercise capacity of this patient, which is what I'm trying to show you in this slide, with an example of an incremental exercise test. So the load increase and the patient does exercise until stops. And all we're trying to do with exercise training is trying to improve the peripheral muscles, improve the oxidative capacity of the muscles, and therefore, for the same level of exercise, people will produce less lactate, and that will imply less ventilatory requirement than pre-rehabilitation, and this will allow patients to exercise for longer. And that's how exercise training works in improving exercise capacity. In this case, I'm showing you peak exercise capacity, but what is probably more relevant is improving submaximal exercise capacity, which will be closer to the level of intensity of daily life activities. And pulmonary rehabilitation does that too, as you can see in this slide. In this case, in a group of COPD, where the endurance time using a constant work rate exercise test was pretty much double after rehabilitation, and that was mainly due to the action of pulmonary rehabilitation and the component of exercise training in the muscle. And you can see before training that the muscle strength measured dramatically falls after fatigue developed due to the exercise, which this population tolerated 11.2 minutes on average, and relevantly that doesn't become better, or the fatigue persists for at least an hour after stopping exercise. And after exercise training, even though these patients tolerated the same stimuli for double the time, there was no evidence of fatigue. And in terms of submaximal exercise, there is an impact at submaximal exercise. And if you compare exactly the same amount of time tolerating that workload before and after training, you will see a significant reduction in the level of ventilation required and the level of heart rate required, which will be of a benefit from people with respiratory and cardiovascular conditions, particularly in the context of underlying diseases in those areas, but also secondary to some of the post-COVID syndromes that may affect specifically the lung or the heart. And we know that pulmonary rehabilitation not only improve exercise capacity, but improve health-related quality of life, and normally does it above the minimal clinical important difference. So in resume, there is obviously, because of this new disease, a slow emerging evidence on how to treat the acute disease. This is the same for rehabilitation. There wasn't enough time to prove that rehabilitation works in COVID specifically, but certainly there's no specific COVID-related syndromes that hasn't been treated with pulmonary rehabilitation with success in the past. So we think that those are common syndromes and not necessarily COVID specific. And effective rehabilitation for patients with COVID in these circumstances can be given on a reasonably sound evidence base. The principles of pulmonary rehabilitation still apply for this patient. Usual pulmonary rehabilitation users are still tributary to receive pulmonary rehabilitation, and some of them may be more deconditioning by the time that they arrive to pulmonary rehabilitation due to lockdown, secondary to shielding, and so on. And some of them may have suffered COVID themselves. The population in need for pulmonary rehabilitation will, because of this, likely increase. And there may be difficulties to deliver pulmonary rehabilitation to a broader number of patients and in the present conditions where there are risks of transmission. So probably these constitute an opportunity also to create new models for delivering pulmonary rehabilitation and think more seriously in remotely strategies to deliver pulmonary rehabilitation to basically overcome the barriers imposed by the pandemic. Thank you very much.
Thanks very much, Roberto. That was really very helpful and very interesting, and it's generated several questions that I think you may be able to help us with. At least a couple really here are about when can we refer, when is the right time, how can we help people, and the sort of the timing. There's one that came in fact, before the webinar in advance. How can we help patients who are still lethargic, weak and breathless 8 to 12 weeks post-COVID? Is that the sort of patient that we should be referring to you?
I think that there is the population with a dramatic change in the condition before and after training that may be affected by some of the sequelae of some of the syndromes. There's people that would have come and would have present severe thromboembolic disease, for example. There would have been people with severe ARDS, some of them even receiving ECMO with some anatomical sequelae in the lung, and therefore this can condition the ability to exercise post-COVID. But there will be that 10% of people that I was mentioning before, the 60,000 patients in the UK with what we call now long COVID. Many of them would have no changes, for example, on the CT scan, on the heart ultrasound, or even the lung function, and still present with fatigue, aches. Some of them will have some level of cognitive problems. Some people will present with unusual tachycardia, and these people are tributary to some level of exercise advice. And there is actually at the moment a nice guideline being produced for the management of these patients. And these patients are normally sent to us, for example, for thorough assessment. Some people we will find some anatomical problems in the lung, fibrotic lung, after prolonged ventilation in the context of ARDS secondary to COVID. But as I said before, we will have a population of people with basically no functional abnormality on the lung function test or the heart ultrasound, or the CT scan, that we would refer to the community rehabilitation for exercise advice. And then depending on the limitation of the patient, then we go to that pyramid that we were talking about from the WHO, and it will be from the minimal intervention depending on the patient's symptoms to the more specific and intense intervention when the patient is experiencing more severe symptoms.
Yeah, and I think you've partly answered the other question that was coming in about people with long COVID or breathless, but with normal chest x-rays, normal echo, normal ECG. And there was a concern that they're getting a diagnosis of anxiety. And should they perhaps be referred for more detailed respiratory testing? Is that something you would suggest is right?
I think I would. I mean, if the patient is suffering from breathlessness, it's probably wise to assess the lung function and see whether there's any alteration on the lung function post the disease. But there will be a number of patients that we will see with a normal spirometry and no problems in the lung function that will still have symptoms. I haven't seen that many of them, so my experience is probably anecdotal. I see a number of patients that are actually slowly improving after a couple of months of having COVID and being quite limited in the beginning, but I don't think there's enough evidence yet to know how these people are going to behave, and we are learning on the go from what's happening with these people.
Yeah, thank you. Well, we haven't got much more time at the moment, but there was a question here which you may be able to give a fairly short answer to. Any idea when the new guidance from NICE will be available?
Nope.
No. Okay, I thought it might be as simple as that.
Yeah, I say, I wanted to be sure, but I think it's imminent. I mean, I think it's under production. Yeah.
Yeah, okay. So it's under production. That's encouraging. Thanks very much, Roberto. We've got a few minutes at the end. We may come back to one or two of the other questions, but in the meantime, I need to move on, and I'm delighted to welcome Tracy Jackson. Tracy Jackson is a research fellow with the Asthma UK Centre for Applied Research. She actually leads the patient and public involvement group. But she's been, during the course of the lockdown, she and some colleagues from the university did a survey and some qualitative interviews looking at the psychological impact of lockdown, and has found some really very interesting information for us. Thanks, Tracy.
Thanks, Hilary. I'll just share my screen now, make sure I share the right one. Hopefully that's it. So as Hilary said, I'm based at the University of Edinburgh. I am the Patient and Public Involvement Research Fellow for the Asthma UK Centre for Applied Research. But during the pandemic, I worked with a team looking at the psychological impact of COVID on people, well, adults actually, with asthma. So it was a larger mixed methods study, but I'm just going to present the qualitative results that we have so far today. So this is what we'll cover today. So background, EM methods, then provisional analysis. So it's not quite finished yet, our analysis. So these are only preliminary results, and then a little bit of a sort of overview implications. So background, March 2020, COVID-19 was declared a pandemic, and in the UK, people at high risk of becoming seriously ill were advised to shield, and this included people with severe asthma. So despite early concerns, those with milder asthma do not appear to be at higher risk of serious illness from COVID-19. So obviously with COVID-19 being so new, we were just learning all the time about it. So there were changing thresholds for risk groups, and there was just a lot of confusion among people with asthma. They felt there were unclear messages for them, and it's led to sort of uncertainty and overestimation of risk among that population. So a timeline, so December last year is when the first deaths were reported in China. In the UK, the cases were first here at the end of January. Then we go into March, where there was the first UK death, and then the UK-wide lockdown was on the 23rd of March. And then in that period between March and April, shielding letters were sent to high-risk groups, and that included people with severe asthma. The 13th of May, lockdown begins to ease, and then the 6th of July is when shielding guidance eases. And the reason that I've highlighted both of those dates is because we interviewed people who were social or physical distancing, whichever terminology you want to use, and also people who were shielding as well. So what did we aim to do? To explore the experiences of people with asthma during the COVID-19 pandemic. So we recruited adults with GP diagnosed asthma from across the UK. We used the Register for Asthma Research database, and also Asthma UK very kindly advertised this on their social media as well, so Twitter and Facebook. So we got a mixture of people, as I said, who were shielding and also social physical distancing. Interviews were conducted by phone by 2 researchers. Initial analysis was done by 2 researchers as well, where we created a code book from our themes, and then we discussed this in a multidisciplinary team with patient and public involvement representation as well. So if we go back to this timeline, we can see this is the time period whenever we did the interviews. So it was after lockdown had begun to ease and before the shielding guidance had eased. But if you remember, actually the shielding guidance kind of got extended at different points, so people weren't quite sure when it was going to end. And so it was in some cases it was quite last minute that it kept getting extended for an extra week or so, an extra time. So we interviewed 26 people. We had 11 male, 15 female. We had 15 people who were shielding, 11 people who were distancing. We had 19 people who had been diagnosed with asthma when they were a child, 7 people who had been diagnosed as an adult with asthma. We got people from across the whole of the UK. As someone from Northern Ireland, I'm always delighted when we get people from Northern Ireland. So 1 person from there, 1 person from Wales, 9 from Scotland, and 15 from England. The interviews they ranged in length from 18 minutes was our shortest, and that was with someone who was shielding, and the longest was 1 hour and 17 minutes. So basically a whole hour longer, and that's with someone who was distancing, not shielding, and they were someone that actually had COVID-19. So that interview was quite different to a lot of them. And people ranged in age from the 18 to 25 group to over 65. So we had 4 main themes. Our first one was health communication. And as you can see here, someone's saying that they found the messaging at the start just really quite confusing. They just weren't sure what was going on. It kept changing. And again, then there was also an overwhelming amount of information as well. So people felt that they were unsure of which sources to trust. They didn't know where to go. There were a lot of forums. So they were going to places like the Asthma UK website. But there was also this confusion from people about why would they be going to a charity website. They would have really felt more reassured if they could get information direct from the NHS, either on an NHS website or from a healthcare professional. So there was a bit of confusion about that, going to the Asthma UK website. And here you can see that someone's talking about having to trawl for information as well. So it was a just overwhelming amount of information, and people just didn't know what to trust at all. So people's mental health, when they talked about it, people were really, really struggling a lot. So here's someone's talking about producing a document that they called their doom and gloom statement. And this person was saying about how they had all of their online accounts, all of their passwords, they got it all put into one document so that they would have it for any of their family members if they passed away after they'd caught COVID. So this person was obviously, in a way, being very productive and trying and very proactive about it and trying to prepare. So there's this sense of preparedness about it, but also she was very anxious, felt very anxious about it. And also she mentioned about how her family were feeling very anxious about, they were very concerned for her as well and her welfare. People here talking about it being an anxious time and also a very lonely time. So this particular person, they were shielding at home with their 3 children. Their husband was an essential worker. And they also talked about just being terrified going out for walks. So this is before they were shielding. She said about how they were really terrified going out for walks because with the kids that she had, the ages that they were, she said they were just touching things all the time, the way that kids do. They wanted to touch the pedestrian crossing button. They wanted to touch a railing. They wanted to pick up a stick. she said like she felt really anxious, and then it was getting transferred onto her kids as well, because she was sort of like not shouting at them, but being very anxious and don't do that, don't do that. And she said it was just a really horrible situation. Also, then someone said about having a couple of wobbles. And here, this is interesting, where this person is someone who's distancing. So that means they haven't been identified as being someone who's extremely clinically vulnerable, but they still felt that they were going to, you know, they were thinking of the worst case scenario. They were thinking of just really that if they got COVID, that they were going to pass away. And so there was this talk about, was this due to the mixed messaging at the start? And a lot of it came from confusion about the fact that COVID is a respiratory condition and asthma is a respiratory condition. So therefore, people with asthma should obviously be worse because they, you know, because they already have a respiratory condition. So there was just a lot of confusion. Another thing that came out within mental health was grief. People felt that they were grieving for lost sections of their life where they had just been shielding. And there was also a lot of anger. At the time when we did our interview, it was the end of May, start of June, and people were talking about seeing other people in their local area breaking rules, but also nationally when there was obviously a high-profile case of someone breaking rules as well. And people were just saying about how they were just really, really angry because they felt they were sacrificing a lot, but they could see other people who weren't doing it. So we talk about shielding with people as well. So here was someone talking about how they were really concerned about getting their medication, and because the pharmacist didn't have any and they weren't doing any deliveries. This particular person actually started shielding themselves in January, and they said that their wife was still working. So for about 2.5 months, they just lived in completely separate rooms. So he said he didn't see his wife for 2.5 months because he was just so frightened of anything that she might catch and bring back to him. He said that he was going to shield for at least a year, if not longer. And he said even when he was told that it would be okay to go out, that he would just make his own informed decision on that. He was doing a lot of research himself, so just very frightened about it. There was also this kind of feeling about shielding, and again, this came from the mixed messages and people maybe not sure what information to trust about their susceptibility to catching COVID, or how severe it might be for them. So this is someone who was distancing, so again, not identified as someone who would need to be shielding, so not identified as someone who's clinically vulnerable, but they were deciding to shield anyway. And then also there was someone who said that they were actually delighted to receive the shielding letter because they just didn't want to be in the middle of it all, and they preferred to just be in their house, and they felt when they had this letter, they felt it was almost like safety for them. So final theme that we had here was the interaction with healthcare. So this was very interesting. Again, it went to mixed messages. People felt that it was a lot of reactive communication. So they felt that they had to, or well, a reactive communication in that way that they felt that they themselves had to get in touch with their healthcare professionals. So this person here specifically was very upset about it because they had a consultant, so they had very severe asthma. And they have a couple of consultants that they work with, and they felt that they really would have felt better having more guidance from them. But they felt a lot of people used words like abandoned and things like that. So there was also a discussion about the way in which messages were conveyed to people. So someone was saying that their GP called them and making sure they were okay, but sort of in the same breath then said to them, you know, oh, do you have access to food? By the way, if you catch COVID, who's your next of kin, and do you want to be resuscitated? So that was also quite a shocking way to receive that message as well. So it's just the way these situations, these questions that do need to be asked, the way in which they are delivered. Sort of overview and implications. Like I said, these are just our preliminary findings at the moment. We're still working on the analysis. But people experienced a whole range of emotions, confusion, the mixed messages, fear, anxiety, a lot of loneliness as well during the COVID-19 pandemic. And what would help would have been sort of clear guidelines and support from the government and healthcare providers. So in the event of a second wave and also any future pandemics, it's having these kind of things ready for people with respiratory conditions if it's a respiratory condition. As I said, this is part of a larger mixed method study, and the questionnaire that we did had over 800 responses to it as well. And from that, then we were able to select these 26 individuals for interviews. So that's fine. Thank you.
Thanks very much, Tracy, for a really interesting insight into how people who are living with a condition like asthma felt during this pandemic. In fact, of course, many people with asthma were better and had fewer attacks. They probably started taking their inhaled steroids for the first time in goodness alone knows how long. Did you get any sense of how people prepared themselves in the way that we would have been recommending they should be looking after themselves for ages?
Well, a lot of these participants seem to be very well-behaved patients with asthma, and they all were like, "Oh no, I always take all of my medication the way I normally do. You know, I always follow the guidelines. I always follow how much I should take. So it's really not changed how much I take it." But I feel then later in some of the conversations, people said, "Actually, I'm a bit more regular. You know, I've got my asthma plan. I know where that is, and I'm making sure that I'm taking my steroid inhaler each day." So yeah, people were definitely a lot more concerned about that, and maybe just keeping more aware of their triggers, I think, as well, was another thing people were very conscious of. But people talked a lot about being inside. A lot of them said that maybe their triggers were things like pollen or pollution, so being inside kept down sort of exacerbations for them as well.
Yeah. Viv Marsh has asked a question about were there any positive experiences?
It was very interesting because as I said, there was someone there when I showed that they said actually they were really relieved to have received a shielding letter, and they were very happy to just stay at home and be away from it all. But I think people just felt very unsettled. That was the majority of it. We interviewed 2 people that had COVID-19, and they both seemed to be experiencing symptoms of like long COVID. They were just saying that they were absolutely exhausted, and just very unusual things as well. Like they'd said about how one of them said about how she first got her symptoms at like midnight, and then she felt at like midnight every day her symptoms got completely worse. So people talked about loss of sleep as well, and just waking up just really frightened all the time. So not much positivity, sorry, Viv.
That didn't sound like a lot of positivity. Now, if Brian and Roberto would just like to join us, we've got a couple of minutes. In the meantime, and this really relates a bit to what you were saying as well, Roberto, Liz Rogers is asking, did anyone comment on how their exercise habits had changed during lockdown? Roberto said they were going to be less fit. Is that what you found as well, Tracy?
No, I find that people are actually, well, they said they were doing more, but there was a lot of PE with Joe going on. There was a lot of that. People also, as coping strategies, on a lot of yoga and things like that, mindfulness. So a lot of yoga, sort of breathing exercises and strength building and things like that. But there were some people that person that I said had not left their house since January, and we did those interviews at the end of May. So I think there's only so much really you can do in your house. Like they hadn't stepped over their doorstep in all of that time, which is quite frightening.
So some are fit and some are not so fit. Okay.
Yeah, with Joe, yeah.
Okay, so there's a few questions here that we can perhaps just cover. A bit about these tests. I think these are probably going to come to you, Roberto, and perhaps to Brian. A bit about the tests that we can do. Una McFadden is asking, do you know how long an infected person continues to pose a transmission risk from aerosol generating procedures? And that probably links to when can we do spirometry again, which is certainly a bit of a challenge to us in primary care. So Roberto, do you want to comment?
Yeah, well, we advise our patient when we discharge them from hospital and they are negative, that there's no any risk imposed. So the other thing is, what are we normally practicing, for example, with aerosol generating procedures? And there is a little bit of controversy around this. For example, with people requiring, home ventilation, and what are the risks and what are the protection measures that personnel and carers that need to go and see these people need to take. And there is probably 2 different views. The view that is more pragmatic and say, well, I mean, there is always a risk and everybody needs to be protected when they go and see a patient at home if you're a carer. and the patient is using an aerosol generating procedure, and make sure that the room is well ventilated, and take those precautions up to after an hour that the patient is not on receiving the ventilation, for example, if ventilation is the aerosol generating procedure. And there is a different approach on, I mean, if there's no evidence of COVID, just treat the patient as a non-COVID, and therefore is the same risk as in normal conditions.
Okay. I just wanted to move on because there's another question very related to it. I don't know whether you want to comment on this one, Brian, because it's about community spirometry. And we're not doing any more. When can we start to do things like community spirometry again? Is this something that comes into your remit at the moment, Brian, or shall I go back to Roberto on that?
I would go back to Roberto on that one, I think.
Roberto, you're going to be landed with that. When can I get my spirometer out in my practice?
I don't know what you do in the community, but certainly in the hospital, we are doing spirometries. And if the patient is asymptomatic, the patient does a spirometry, and it's just that the personnel is protected with gown, gloves, and a shield.
Yeah, it's my experience too that spirometry is just not happening in the community. Everybody's got very concerned. One more lung function question, and then I think we've reached our time. It's about breathless patients and reduced CO2 diffusion capacity, because there is this breathlessness that we can't seem to pick up on any tests, and it came up in a question before. Is there a way of detecting abnormal respiratory function that is proving helpful in this context?
Yes, I mean, I don't know. I don't think personally that necessarily the absence of breathlessness acutely with such a level of desaturation had anything to do with the diffusion. Is probably the other way around, and there are some articles pointing perhaps at some problems in the respiratory center. On the other way around, if the question is, can people post-COVID experience a reduction in the diffusion capacity? Well, the answer is yes. And it was yes with other coronavirus in the past, that it is associated in some patients with persistent reduction on the carbon monoxide diffusion capacity. And it seems to be more related to a truly abnormality in the membrane more than with a lack of volume or the loss of volume. And nobody knows whether that is reversible. I suppose that depending on the level of damage of the lung, but even in minimal damage, there can be reduction on the LCO. And in the SARS epidemic, there were reports that may persist up to 2 years after recovering from the condition. And I don't think there's an answer yet on what is going to happen with the COVID-19.
So that's really very interesting, and thank you for that. I am going to call time. It is actually just on 8 o'clock now, and I think your point there about, we're finding out more, but there's a comment here. Health professionals need to have the confidence to say we don't know the right answers at times, and in this context, I think that's probably very true. But maybe we know a few more of the right answers after this evening's webinar. So thank you very much to the three speakers, to Brian, Roberto, and Tracy. That's been really good. I want to thank Wendy and Clara and Susan, who've been managing the logistics and making sure that this webinar actually happens. So thank you to them. Thank you to Milan, who of course sponsored this evening. We're very grateful to that. And thank you to those in the audience for asking questions and joining in the discussion. So thank you very much, and good night to everybody.
Thank you.